Hello, and welcome to the Smart Injury Doctors Podcast, the injury market's top program for doctors, lawyers, and insurers who want to gain greater insight on how to improve patient recovery results and deliver better services in the U.S. injury market. Please welcome your host, Dr. Jeffrey Allen Kronk.
Okay, doctors, what I want to talk about today is don't use imaging to explain your failures. Now, I know that sounds a little bit harsh, and it may be, but here are the facts. When a patient has an injury to the spine, the research shows that they have a very poor recovery rate. 55% or greater chance of never fully recovering. That means their headaches don't go away. That means their chronic neck pain doesn't go away. That means their chronic lower back pain doesn't go away. That's what that means. And so they have a very small chance, they have a high risk of not fully recovering, and they have a small chance of a full recovery. Now, the doctors that I help work with across the country, called Smart Injury Doctors, the whole idea, the whole movement is that patients that actually have spinal injuries should be going to the best doctors possible. They should not go to the doctors in the middle of the bell curve. They should be going to the doctors in the front of the bell curve. And the doctors in the front of the bell curve, one, know what spinal injuries look like. Two, know how to work them up. Therefore, their documentation is stellar. And three, and the most important part, is they get great injury recovery results. And they don't need to have anybody else to do those results. What I mean by that is many of them have everything that they need right in their own clinic, right? In the future with AI, in the future with improvements, when a patient has an injury, there should be a monitor, like a heat map in your local area that says, oh, you got this condition? All right, what doctor is best at treating it? And by what I mean by treating it is by getting a good physical recovery result from it. Today, too much. So the reason why I have done everything I've done in the excessive motion testing. By the way, it's the only way that you can determine how badly damaged the non-disc ligaments are in the spine. So without an excessive motion test, you really don't know how badly damaged the spine is. It's a key component. It's a key derangement pattern. And in the future, no patient that injures their spine will go without a excessive motion test. Just like nobody that is, concerned about did they herniate the disc is going to go without an MRI, or a person that says, I don't know, on the X-ray, I think there might be a fracture here. Maybe we should do what? Try the CT. So no one's going to do that. But there's another breed of doctor today, and that breed of doctor, and I understand this completely, because no matter what, I was very good in clinic, but I didn't get every patient fully recovered, right? There are circumstances, there are pre-existing condition circumstances that make full recoveries harder. Now, full recoveries can be, what I'm talking about is where the person without some form of supportive care seems to regress. And supportive care is a really good thing. You can also call it maintenance care. If it's to support a condition so the condition doesn't regress, it's called supportive care. If it's care to try to get rid of something before it ever occurs, it's called maintenance care, right? So I'm not saying that these patients are going to 3 months, 6 months in your clinic fully recover just like they did in mine. That full recovery is, what are they going to do for the next 6 months, the next year, the next 2 years, the next 10 years, the other 30 years? Is there going to be accelerated degeneration with these? Okay, so your imaging is what allows you to determine what you need to do with the patient to get better results, not to explain your failures. Although it works both ways, it can also explain your failures. Now, I always looked at a patient and I looked at it and said, gosh, I'm shooting for 100%. If I didn't get 100% correction, if I didn't get 100% reduction, I felt like we failed a bit. Now, that's me. That doesn't have to be you. That's me. Right? And I wanted to fail as little as possible. I wanted to succeed as much as possible. Now, your imaging, the results of imaging, especially in a non-disc ligament injury, the results are permanent. It's a permanent injury. We don't know right now, maybe PRP, maybe stem cells in the future. If the environment opens up, maybe we can get some really cost-effective ways to go in there and regenerate that nerve. Who knows? Maybe tomorrow, a laser, a soft wave, something will actually show up that says, hey, we can target heat the ligament and shrink it. Or maybe we can actually target the stem cells right to that particular area and have it repair it and regrow it, whatever. And we do that in combination with things like spinal adjusting or physical therapy or various things that we know that have a good rate of recovery. But the biggest thing is you're using your imaging to drive what your understanding of the condition is. If I've got a patient that's got 2 levels of alteration motion segment integrity in the cervical spine, 2 levels of 3.7 millimeters of translation, and one of the other motion unit right next to it is 3.9. Okay, if I have that, then I know, 1, I have surgical levels of it. 2, I know that I have alteration motion segment integrity. I know what the impairment guide says about it. And I know it's a permanent injury, right? But I got a patient that's sitting right in front of me, and I don't want it to be a permanent condition that basically causes them to suffer for the rest of their life. So what am I going to do? Well, 1, I'm going to stabilize it. I'm going to do everything in my power to stabilize it. And when I stabilize it, I'm going to keep it stable to the best of my ability. And that's what you can do as a doctor, right? Now you can say, well, okay, we didn't get 100%. Yeah, the factors we were working on. Okay, there's 2 sides to those factors. There's you and the patient. And you have to look at both. What can I do better? What could the patient have done better? So you don't use imaging to explain your failures. I know that sounds really kind of rough, like I'm being rough. But I'm only being as rough, I guess, as I ever was with myself. And myself in clinical practice. So when that patient has an instability, you got to do whatever it takes. And so part of it might be, gosh, you have to confront the person on the fact that after care, after their injury care or whatever, they may have to come out of pocket for supportive care. You have to care about them enough to actually get them to continue to allow you to guide them so that they don't have a serious problem. And, you kind of look at it. I look at it and I say, well, gosh, what's the alternative? I can go out there and I can go ESIs, epidural steroid injections, right? I can just pull up on ChatGPT and I can say, hey, what's the effectiveness rate? And it'll say, hey, a review by the American Academy of Neurology found that while ESIs reduce pain for 24% of the patients for about 2 to 6 weeks, their long-term effectiveness beyond 3 months is minimal. Now, there's other studies that say, hey, maybe it's a little bit better than that. Okay, but the bottom line is, if that's what I'm competing against, I can do way better than that. I can do way better than that as a DC. The reason why, people think that I got involved with excessive motion testing or trying to actually set up and standardize spinal injury workups because I could make some personal injury attorney a bunch of money. I don't care about any of that. I care about saving the insurer money just as much as I care about the help that it provides for a plaintiff attorney to make money. Okay, clinical rationale really has no ally. You're not trying to use it for someone, to be an advocate of something. What you're using it for is to be the best doctor that you can be. When a person comes in, let's say a baseball player comes in with a permanent shoulder injury, right? He just had bad ligament damage to one of the main ligaments in the glenohumeral joint. Okay. He knows that that's permanent, but he doesn't want the effect to be permanent. He doesn't want his miles per hour to be reduced. He doesn't want anything, right? I can take permanent injuries. I'm just going to use myself. I'm going to use myself now. Have I broken bones? Yeah, broke my leg badly in football. Okay, do I suffer any pain from that? 0. Now, did it slow me down? Yes. So I had a little bit of functional loss. When I was 40 years old, I broke my Achilles tendon. Wasn't smart enough to get it surgically repaired. About a 2-inch gap. Did it hurt? Oh my God, it hurt like crazy. Right? I walked around in a boot for, I don't know, maybe 12, 15, 16 weeks, adjusting patients every day in a boot. Not smart enough to get that thing to get repaired. Now, is my Achilles tendon a permanent, when I broke my Achilles tendon, is that a permanent condition? Yes. Do I suffer any pain in my leg? Not after, first 12 weeks. I haven't suffered any pain in that leg at all. Now, has it reduced my function? Oh, 100%. If I could go back, would I have it surgically repaired? 100%. Right? But I didn't have a doctor at the time that really cared enough to say, look, you're being ridiculous. I know you're a chiropractor. I know you like, this idea of natural rehabilitation, but you can't naturally reattach something that's not attached. So, part of being a doctor is, and I learned this from my own errors, trying to be the doctor for myself, it wasn't the greatest idea. And I noticed from my own errors, okay, gosh, I need to be a good doctor and control people a little bit when they don't know for themselves what to do. And I use my imaging to drive that. The conditions in imaging, a lot of them are permanent, but the effect that the patient has with that permanent condition is not permanent. And to say otherwise is really an error when you're working with the patients. It really is. Now you can tell them, look, this is a permanent injury. This is a permanent hyperstretch. You take a non-disc ligament injury that causes excessive motion. It's like, hey, you grab a beer 6-pack, grab a corner of one, you put your 2 index fingers in one of the circles, and just pull it, slightly pull it. You're going to feel it resists change. But once you overwhelm it, you'll see it hyperstretches. That's what these ligaments do. Now, you'll see that circle that you just hyperstretched can never be the same. You couldn't put a beer can back in there and have it hold it. It's never the same. But the effect that permanent ligament injury has on a human body does not have to cause them chronic pain for the rest of their life. So, yes, I know we all want to say that. We all want to say that. There are so many cases in your clinics and my clinic where the person had a permanent injury, and when they have a permanent injury, let's say they have a 25% whole person impairment, they're qualified for spinal fusion surgery. That's not going away. That can accelerate in degeneration if you don't do something with the patient and monitor it. Treat them. Take another x-ray 2 years, 3 years down the road and see if it's progressing so that they can make better changes. Maybe they're smoking cigarettes, a pack a day, and you take an x-ray 2 years down the road and you realize, wow, their degeneration is speeding up pretty good. Maybe it's not a good idea for them to smoke cigarettes. Maybe it's not a good idea for them to drink half a cup of water and maintain continuous dehydration. Maybe that's not a good idea. Not for that patient, right? So there's all kinds of ways that you can look at it, but the bottom line is, what matters today, you want to go, hey, I want to build a really big, successful clinic, focus on patient results. Now, you got to focus on all the other things too. You got to focus on documentation. You got to focus on billing. You got to focus on coding. You got to focus on your relationships. You got to focus on presentations to attorneys. You got to focus on your market. You got all these things to focus on. But don't ever lose focus of the reason why you're focusing on those other things. And that's at the end of the day, no matter it's you, associate, you got 8 clinics, you got 200 clinics, I don't care. You got people in there that are in with you or with your doctor or doctors that are in there because they want to live a life without pain. That's the primary focus. Any other focus is not really that valid of a focus. Everything else, now your imaging, your what you're using for your modalities, what you're using with your care plan, everything else is geared toward that. And everything else is it's not that hard to do. Having a really solid spinal injury clinic is not that hard to do today. There's many cool things that you can do that seriously enhance patient outcomes. But you got to focus on that and don't, again, let your imaging be the reason. Hey, look, the reason why we never get great results is because the person has a permanent spinal ligament injury. Well, I'm going to tell you, doctor, there are people that are getting great results. And if it was you and you were self-treating and you don't get good results, you probably would go, hey, I want to go to somebody else. But because you have a financial incentive, you don't send people to anyone else. And I know I may be speaking to you, and like I said, it may sound a bit cruel, but you want to always be enhancing yourself so that you understand your job is to get better results with those patients. Everything else is just the part and parcel of the injury market. You get into the injury market, patient comes in, they got an attorney. You're in a medical legal situation. One attorney's going to, they're trying to actually go, hey, the person's really badly injured. I got to get my, they're worried about claim value. The other side's worrying about, hey, let's minimize this. I don't think my client, my person on our side was fully liable for the accident. Maybe we should share liability. I don't think these injuries could be caused by this level of accident. And I basically also think there are problems with this. They got pre-existing conditions. There's inconsistent documentation amongst the doctors. One says this, one says that. That's the life of personal injury. And so you live with that, but the reason to stay involved with it and to stay enthusiastic in that environment is that patient. Doctors, that's all I'm going to talk about on that today. I hope that resonated with some of you out there. And if you have any questions about our program, it's a Smart Injury Doctors program. Just go to smartinjurydoctors.com. We make it very easy for you to set up a meeting with me if you want to find out more about the program. As always, I appreciate your time, your attention. I appreciate what you do for a living. Trust me, I really do. And I look forward to delivering more content to you on the next podcast.
You've been listening to the Smart Injury Doctors Podcast, the #1 audio production show for professionals in the U.S. injury market that want to deliver better injury services to the patients, clients, or insureds they serve. If you like what you heard today, please leave us a review and don't forget to join us on our next program.